So welcome to Road to 250. Today we'll talk about acid-base physiology and the fun old stuff about acid-base. So getting into it, I like to use this equation as like an acid-base equilibrium equation. So essentially the things that you want to take from here are you have carbon dioxide and water inside your body, and they're in the human plasma. And what they're trying to do is, so there's like an equilibrium between carbon dioxide, water, and bicarb and hydrogen. So what here is, this is the hydrogen atom that determines your pH. And so this will always be going back and forth, either going left or going right. And it's just trying to keep everything equal. So if the pH is too high or too low, then it causes things such as proteins not to work. So there's a tight concentration. And as you see here, bicarb, obviously we know, is maintained by the kidneys and via the metabolism pathway. And then CO2 obviously is maintained by the lungs. So just keep that in mind. It's a general formula that I'll use throughout the presentation, just to get you guys to think about stuff in a different way, presented in a different way. So if we're talking about here, so when it says you're using low values of bicarb, so when the bicarb level is low, what's going to happen? Everything is going to try to shift this way. So so that will cause a high amount. So when this is low, it's going to cause a high H plus concentration because everything's going this way. So that's why you're going to get a low pH value. And this is when you get an acidotic condition. And when you have a high bicarb, everything's going to try to shift left, and it's going to cause high or low amounts of hydrogen atoms, and that's why your pH is high. And that's the alkalotic condition. So in respiratory issues, again, if you have CO2 levels and they're low, if you have low CO2 levels, everything is going to try to shift this way to increase the CO2 level. So then your hydrogen atoms are low, and that's why your pH is high. But when you have a high CO2 level, what it's going to do is everything's going to try to shift this way to equalate the bicarb. And this is also the way that you think about compensation. And that's why you're going to get a low pH, because you're going to try to make more bicarb. But by making more bicarb, you have more hydrogen atoms free floating. So does that make sense?
So far, yes.
Okay. So you can also use the Henderson-Hasselbalch equation. I'm not going to really try to go too much into it, but if you have a high PCO2 level, then you're going to get a low pH, as same thing as you see here. And then a low PCO2 level obviously will lead to a high pH. So the same way this thing works, but you can use it in a different form. So when we're talking about acid-base equilibrium, we're going to do 3 blood measurements to determine the status of this equilibrium. So we're going to look at the normal bicarb, which is usually between, I think that's an error, 22 to 26 should be, sorry. That's an error. So it should be 22 to 26 generally. And every book is going to differ. So you may see the values change a little bit, but generally this is what you're going to see. With the CO2 or PCO2, you're going to have between 35 and 45, and then your pH obviously 7.35 to 7.45. And we're going to use the arterial system to get the blood gas for CO2, because we want to get that level before it goes to the tissues and metabolism occurs. So that's why we're going to use the arterial system to get the CO2 blood. So when we're talking about acid symptoms, we're going to probably think of hyperventilation. So this is like your Kussmaul's breathing, because your brain recognizes the acidic blood and it needs to react, and it blows off CO2, like an immediate reaction. So if you use this equation, just in general, so if you decrease the CO2 value here, right, everything is going to go drive towards the CO2 value because it wants to increase it. So then that's why you're going to lower the H concentration. So this is specifically talking about acidosis, but when you have high acids, you're going to have normal CO2, but the compensation method is basically to remove that and have everything go shift this way so that you will get lower values of H concentration. It can also cause depression of the myocardial contractility, so decreases your cardiac output, and in the it causes cerebral vasodilation and increases your cerebral blood flow and ICP. So just know that for acidotic symptoms. And it can also cause CNS depression, and that's very, very high CO2 levels, and can cause hyperkalemia because when you have a high H concentration or hydrogen ion concentration, it shifts into the cells in exchange for potassium. And there's a shift in hemoglobin dissociation curve, as we've discussed before. That's called the Bohr effect. So if I draw that out for you guys, just as a quick reference guide, my shapes are not going to be very good. But here you're going to have your O2 level and your hemoglobin here. So when you have an acidic condition, what's going to happen is it's going to shift this way. So if that's going to be your new curve for every given O2, so if we measure the O2 here, and this is not very good because it's not very even, but assume that that's right there. For every given O2, there will be less saturation of hemoglobin on the normal. So, and the reason for that is the hydrogen ions basically push the O2 off the hemoglobin, and that's why you have O2 that leaves hemoglobin and it's less saturated. So that's the Bohr effect, and that's why it shifts the hemoglobin curve to the right. Does that make sense?
Mm-hmm.
Okay. And we kind of went over that yesterday with the low pH and what it does to the hemoglobin. It releases more oxygen. So in alkalosis symptoms, it's basically inhibition of the respiratory drive. Your brain wants the body to retain the CO2 to increase the H plus concentration to bring the pH back to normal. And again, it can also cause depression of the myocardial contractility, and it causes cerebral vasoconstriction and a decrease in the cerebral blood flow. It can cause hypokalemia because it shifts the potassium into the cells, and it shifts the hemoglobin dissociation curve to the left. So it's opposite of what we saw in the other one. So how do we approach an acid-base problem? First, we want to check the pH. Obviously, if the pH is less than 7.35, it's an acidosis. If it's greater than 7.45, it's an alkalosis. Next, you want to check the bicarb level. And again, like I said, the normal is 22 to 28 or 22 to 26. Most people can remember the average of 24 for bicarb. And then PCO2, normal is 35 to 45. If you want to think of the middle one, it's 40, if that helps you. So then you're going to look at the acid-base disorder and say, what disorder is it? If it's an acidosis with a decrease in your bicarb, it's a metabolic acidosis. If it's an acidosis with increase in PCO2, it's a respiratory acidosis, so forth. So, and alkalosis with increased bicarb, it's metabolic, and decreased PCO2 with an alkalosis of pH is respiratory. So that's for metabolic acidosis only, we're going to add an anion gap calculation. We'll cover that when we talk about metabolic acidosis later on in the presentation. And you're going to use special formulas to check for mixed disorders. So these are combined respiratory or metabolic disorders. I'm going to strictly kind of just follow first aid and just do one, which is the respiratory metabolic mixture. There are other formulas you can use to calculate metabolic disorders or subs of those types, but I'm only strictly using one formula today. And you want to make sure and ask yourself, is the compensation right? or is the appropriate compensation? So compensation, when you have a decrease in bicarb and you have a metabolic acidosis, what do you think is the compensation? So the compensation will be decrease in your PCO2. So you're hyperventilating to let more of the CO2 out. So if you have a high bicarb and it's a metabolic alkalosis with a high pH, what is the compensation?
Depression of the respiratory drive?
Yeah, so you're going to have high PCO2 as your compensation. If the PCO2 is high and it's a respiratory acidosis, what's the compensation?
So increase in bicarb by the kidneys.
And we'll talk about that in the next picture here. And if you have a decrease in PCO2 and respiratory alkalosis, what is the compensation?
Decrease in bicarb?
Yeah, decrease in bicarb. So pretty much the arrows follow itself. But here is the first aid picture, and it kind of helps you. But the key things that you want to think about here is with any sort of metabolic acidosis or alkalosis, the compensation response is immediate because the brain recognizes that change very suddenly. Anything with the respiratory, it has an increased reabsorption of bicarb. It can be delayed because either you're creating new bicarb or it's going to take some time to increase the reabsorption of bicarb. So these two can be delayed, but this is rather immediate. So the thing that I want to talk about is cause versus compensation. So how do you know what is causing it and what is compensating it? So in most acid-base disorders, your bicarb and PCO2 is going to be abnormal. So so one is the culprit, the other one's causing the disorder. One is the culprit, which is causing the disorder, and the other is the compensatory change. So let's test this, and I'm going to give you guys an example. So if your pH is 7.3, was it an acidosis or alkalosis?
Acidosis.
Acidosis. And I'm going to tell you that the bicarb is low and PCO2 is low. Now, in this case, I'm going to tell you that it's a metabolic acidosis with a respiratory compensation. Does anybody want to guess why? Or explain why that could be?
So it's metabolic acidosis because you have a decrease in... Oh, no, never mind. If you have a low...
You're blowing off the acids?
Okay, so I'm going to use this because I kind of makes perfect sense for me, but let's see if you guys can understand. If I decrease PCO2, and the only reason I'm going with that is because it's not the right one. So if my PCO2 is low, I'm not messing anything with my acid. I should be more alkalotic because I'm shifting everything this way to increase my PCO2 level. So that would mean pH would go up. Does that make sense? If I was to say, why is this not respiratory acidosis? Only because if I decrease the PCO2, this whole equation shifts to the left, and that will increase the number of hydrogen ions, or decrease the number of hydrogen ions. Does that make sense? Mm-hmm. Now, if my bicarb is low, everything is going to try to shift this way to increase my bicarb. So when I try to increase my bicarb, I'm producing more hydrogen ions, and that's making it more acidic. So only a low bicarb would drive the equation to the right, causing an acidosis. Decrease in CO2 is a compensatory change for the low bicarb because it's trying to push everything to the right to create more bicarb or more. Does that make sense?
So it's trying to blow off the excess?
Correct. Yeah.
Excess hydrogen?
Yeah, essentially. Because by doing that, by blowing more off, I'm going to end up switching this equation going to this way. Okay. So if I decrease my CO2 level, my body's going to say, whoa, let me create more CO2, and that's going to cause less hydrogen production. That's going to, the thing to do with that is it's going to increase my pH back to the normal setting. So that's why this is compensating for this. Did I confuse anybody, or do you want me to try that again?
Let's do it one more time.
All right. So let's say the metabolic acidosis. So that means my bicarb is low, right? So what happens when your bicarb is low? It's going to try to make more bicarb. By making more bicarb, it's going to create more hydrogen ions. That's going to make it acidic. But to compensate for the low bicarb, your body's going to say, whoa, I need to blow off my CO2, and it's going to start decreasing PCO2. By decreasing PCO2, the body's going to say, let's shift this going to the left. So that means by decreasing my PCO2 level, I'm going to end up increasing my pH level because I'm creating more CO2 instead of bicarb. Did that make sense?
Yes, that was good. Good to get it twice.
Okay. Everybody else cool?
Yeah, I think so.
Okay, I'll give you another example. Hopefully this one will make sense. So here your pH is, again, acidotic, but your bicarb is high and PCO2 is high. So I'm telling you that this is respiratory acidosis with a metabolic compensation. Why? If I have a high PCO2 or high PCO2 value, what is that going to do?
It's going to shift the curve over to
So everything's going to try to go this way. So what it's going to do is going to create more hydrogen ions, which is going to lower the pH. That's why it's an acidotic. Now, for your body, is going to say, I have too much bicarb. I need to get rid of this bicarb. Or it's going to start producing more bicarb and reabsorbing more bicarb. And that's going to increase your bicarbonate level. So then your PCO2 level, it's going to, it's trying to fix the problem by increasing the bicarb level. So trying to help the curve shift this way to decrease the hydrogen ions by increasing production or reabsorption of bicarb. That's why that's the compensation here.
So the bicarb is the metabolic compensation?
Correct. Yes. So this patient has a respiratory acidosis to start, and the body's reacting to that by doing a metabolic compensation.
So in the first example, we have a metabolic acidosis and the respiratory compensation. So that's the PCO2 piece?
Yeah. That's why this is low. So initially your bicarb is low. So when your bicarb is low, it's going to produce more bicarb. So your shift is to the right. But your body realizes that, and once you become acidic, it's going to say, let me blow off this PCO2. And once it blows off this PCO2, it's essentially trying to shift this curve back this way so that you don't produce more hydrogen ions to become more acidotic. It's trying to go back to its normal 7.35. And the way it does that is by lowering the PCO2. Does that make sense? It's probably a bad example, but I mean, I'm just trying to show cause versus compensation. I'm not trying to.
Well, so to summarize, basically, if it's the first part of your example, where it says metabolic acidosis with respiratory compensation, so that means the metabolic portion is talking about bicarb. So metabolic acidosis, bicarb low, with respiratory compensation. So that means the CO2 is what's going to be doing the compensating and end up being low to bring it back to the other side. And it's the reverse in the other one, because it's the CO2 that is the issue in the respiratory acidosis, and then the metabolic compensation is the bicarb getting high in order to compensate.
Yeah.
Okay.
Sorry, this is probably a bad example, but I just wanted to show that there's how you can think about this, because it's not always when you see both levels are low or both levels are high, it doesn't mean that both of them are the issue. One is helping the other fix the problem. So this examples, I know that these are not, because there's no values associated with them, but I just wanted to show you that how you can think about it using this formula or just approaching a question. So I hope I didn't confuse anyone. If there's any confusion, I can still go over and try to explain it a different way. Okay, so then we'll talk about the compensations that we do in our bodies. So respiratory, either we hyperventilate, so blow off CO2, and that will, plasma CO2 levels will fall, and then there will be less hydrogen in the blood, and your pH will rise. Or we hypoventilate, and that is where we retain the CO2 levels, and plasma CO2 levels will rise, so you get more hydrogen in the blood, and your pH will fall. So the first one, when you hyperventilate and you blow off CO2, this is your acidosis compensation. And then the second one, where you hypoventilate, is going to be your alkalosis compensation. Does that make sense?
Mm-hmm.
Okay. And for the renal side, if you have an acidotic, the compensation with this will be excess hydrogen is filtered or secreted into the nephron, and your bicarbonate is reabsorbed, and that's going to happen in the PCT. So your bicarbonate will go up, and your urinary buffers are excreted. Basically, these are buffers that will help excrete the excess hydrogen ions, so it doesn't damage the nephron. So you can use phosphate or ammonium as buffers, and these will bind to the H+, and then they prevent a severe drop in pH. So that's another way your renal compensates for an acidotic situation. And if you have an alkalosis, it's just reverse of the acidosis, so everything is opposite. So now, talking about mixed disorders, there are two disorders at the same time. So you can have a metabolic acidosis and a respiratory alkalosis or an acidosis. You can also have a metabolic acidosis and a metabolic alkalosis, or just two metabolic acidoses. But they occur in pathologic states such as vomiting and diarrhea. And to uncover or determine the expected response, we're going to look at the expected bicarb for a respiratory disorder or expected CO2 for a metabolic disorder. And we're going to use formulas to determine that expected response. So if the actual or expected don't match, you know that there's a secondary disorder present. So just real quick, when you have a mixed disorder, so in a normal setting, actually, let me just go through this. In a normal setting, when you have a metabolic acidosis or an alkalosis, and the pH changes, it can never compensate to the normal pH. So it can never go back just alone to the normal pH. So in a mixed disorder is when you will see the differences when the pH will go back to its normal side. So what I'm trying to, I think I probably confused myself, but when you see a mixed disorder, the pH will be normal, which is not normally seen in any sort of other disorders. When you have other disorders, the pH will either be high or low. It will never go back to normal, even with the compensation. So if you have a metabolic issue and you do a respiratory compensation, the pH will never go back to 7.35. But if you have a mixed disorder, the pH will go back to its normal setting. And that's one way you can think about that. So when you see a question and you see the pH is normal, you can say that it might be a mixed disorder. It's just a kind of like a hint. So if the actual and expected are not the same, you determine the abnormality. So your CO2 is higher than expected, or bicarb is lower than expected, and you can use these secondary rules. So when you have a high CO2 level, it's an acidosis. Low CO2 level than expected, it's an alkalosis. So these are just basically giving you actual versus expected. So if this doesn't match, then you can think about these as a possible respiratory or metabolic mixed disorder. And I'll go through an example of that in the next slide. So metabolic acidosis compensation, let's talk about that one, because your compensatory respiratory alkalosis. And we're going to talk about this, and we're going to see hyperventilation. So we're going to use the Venters formula. It tells you the expected PCO2 in a metabolic acidosis situation. So if the actual CO2 is not the expected CO2, then you have a mixed disorder. And I have several examples where we'll see that. So the formula is the PCO2 is 1.5 times the bicarbonate level plus 8 and then plus or minus 2. So keep that in mind. And I'm going to ask you guys to do some math on the next two slides, or the next slide. So this is just from first aid. It's the predicted respiratory compensation for a simple metabolic acidosis, and then can be calculated using the Venters formula. So if the measured PCO2 is greater than the predicted, then you can say it's a respiratory acidosis. And if the measured PCO2 is less than the predicted, then it's respiratory alkalosis. So let's do some sample problems, and hopefully this will help you guys with that one. So the pH is 7.2, and bicarb is low. So is this a metabolic acidosis or no? If based on those levels.
Metabolic acidosis?
Yeah, because your bicarb is low and your pH is also low. So now we know that it's a metabolic acidosis. So the compensation obviously is going to be with your CO2. So let's test it. Is it a mixed disorder, or if it's a simple metabolic acidosis? So what is the expected PCO2? Can you guys help me calculate that?
So 9 times a half, which is 4.5. Yeah, so 13.5 plus 8. So what is that? 19 or well, no, that's not right. 22.5.
So it's 21.5, or we'll round up to 22 plus or minus 2. So the range should be, your expected PCO2 calculation should be between 20 and 24. And if we see here, it's at 22, which is what we expect it to be. So there is no secondary order. It's compensating right exactly how it should. Does that make sense?
Yeah.
All right, so let's take a second example. pH is 7.28. Bicarb is 12, and PCO2 is 40. So pH is low, bicarb is low. So obviously it's a metabolic acidosis. Your expected PCO2 in this case, if we plug in the formula, 1.5 times 12 plus 8 is about 26 plus or minus 2. So the expected range should be between 24 and 28. So clearly we have a high PCO2 level here. So in this case, this person has respiratory acidosis secondary disorder with the metabolic acidosis. Does that make sense?
Makes sense that you got to have that Winters formula on your cheat sheet.
Yeah, I would. The other thing that you could use is your PCO2 is at 40. It should never be normal if your bicarb is low. So that could also give it away for you. That if the bicarb is low, you know that this is going to do something. It can never be normal. So that's your first sign. And your respiratory compensation is, as we said, was very immediate. So the body will quickly lower the PCO2 to compensate for the acidosis, as you see in this patient. But it hasn't, so it has a respiratory acidosis as the second. Cool. So this is what we've seen in first aid all the time. You check the arterial pH, and then we can either do metabolic or respiratory acidosis or respiratory and metabolic alkalosis. What I'm going to do is I'm going to go through each of them individually as best as I can and as quickly as I can, and we'll go over each of those specifically. So with the respiratory alkalosis disorder, obviously your pH is going to be high and your PCO2 is going to be low. So that's an alkalosis. And the causes are by hyperventilation. And some of these causes could be like pain. Surgical patients who've just recently had surgery can see this, or people in high altitude response. And then early aspirin overdose can also see respiratory alkalosis. But there are other situations such as tumor or pulmonary embolism. And if you have a panic attack, you can also see this. So those are some examples, and I'm going to go through the last two in more detail. So in a high altitude, you have a low atmospheric pressure, low PO2, so it causes hypoxia, and that causes you to hyperventilate, and that will decrease your PCO2 and cause a respiratory alkalosis. Your pH will rise, and after 24 to 48 hours, the kidneys will excrete bicarb, and your pH will fall back to normal. So the ventilation rate at that point will also decrease, and you can give acetazolamide to augment the excretion of bicarb. So strictly just in high altitude situations, that's the pathophysiology behind that. Now, aspirin is a funny one because it's a tube acid-base disorder. So shortly after ingestion, you may see respiratory alkalosis because your salicylates stimulate the medulla, and that's where your respiratory control centers are located, in the medulla, and that will cause you to hyperventilate. However, hours after the ingestion, it becomes an anionic gap, metabolic acidosis. And we'll talk about that one more specifically when we do metabolic acidosis. But I just wanted to tell you that it's a two-base or two-acid-base disorder, and it can be either one. Any questions with that one? If not, we'll move forward. So with respiratory acidosis, you're going to have an increase in PCO2, and your pH will be less than 7.35. Again, you're using this equation. If I increase my PCO or CO2 levels, everything is going to shift to the right to basically balance out, and that's going to cause more production of the acid, and that's why your pH will drop, go to 7.35. All right, so it's caused by hypoventilation, and certain diseases that you'll see this is in lung disease, such as COPD or asthma. Narcotics, you can see this, and cases where you see respiratory muscle weakness, such as myasthenia gravis, ALS, Guillain-Barré syndrome, and muscular dystrophy. So, and other places that you may see will be airway obstruction, if you have acute lung disease or chronic lung disease, opioids, and obviously the respiratory muscles. And those are the examples that you may see. They may not give it to you directly, but those are some of these examples. Any questions before we move on? All right, so in metabolic alkalosis, you're going to have an increase in your bicarb level and a decrease or an increase in the pH, sorry. So if I use that equation, which I don't think I put in here, but basically increasing your bicarb level will cause everything to shift to the left, and that will basically try to bring down, or when it tries to go to the left, it'll decrease the number of hydrogen ions, and that will cause an alkalosis. Your pH will increase. Some of the causes will be contraction alkalosis, hypokalemia, diuretics use, vomiting, hyperaldosteronism, and antacid use. So the key takeaway you want to take from here is a loss of hydrogen from the body or a gain of bicarb, as the way you can see a metabolic alkalosis question or a situation. So As you see here, either you have a hydrogen loss from the body or bicarb access. And some of the diseases that cause an increase in the pH and increase in your bicarb will be loop diuretics, vomiting, antacid use, or hyperaldosteronism. And we'll cover that in 2 slides. So there's some keys to diagnosis, and first is a history, obviously. Second would be the fluid status of the patients. If they're volume depleted, such as vomiting or have GI losses, you can use the urinary chloride as a test, and I'll cover that more when we talk about vomiting. And then IV fluids will help resolve most forms of metabolic alkalosis, except hyperaldosteronism and hypokalemia. So let's just talk about the 2 that first aid doesn't have, which is contraction alkalosis. So this is when you decrease the effective circulating volume, and that causes the renin, angiotensin, aldosterone system to be activated. What it does is it increases hydrogen secretion in the PCT due to the angiotensin 2, and increases bicarb reabsorption in the PCT due to that increased hydrogen secretion. So we know that in the PCT, bicarb is converted to H2CO3, and then what molecule converts it to? CO2 plus water. It's carbonic anhydrase. So then carbonic, when it converts it to CO2 and water, it goes inside the cell, and carbonic anhydrase will convert it back to bicarb and hydrogen ion. The hydrogen ion will go back to get more bicarb, and the bicarb will go inside the intestinal or blood side of the lumen. So just a quick kidney physiology review for you. And there's also an increase in the secretion in the collecting duct due to the aldosterone. And in hypokalemia, the potassium can exchange with the hydrogen ion to shift in and out of cells. So when you have a low potassium, it shifts potassium out of the cell, and hydrogen inside, it'll just exchange itself. And when you have hypokalemia, it leads to alkalosis, or when you have alkalosis, you may see hypokalemia. So it can go both ways. So just keep that in mind. So here we've talked about metabolic alkalosis with loop diuretics, vomiting, antacids, and hyperaldosteronism. So I'm going to go through those in more detail. So when you're taking a diuretic, such as a loop or thiazide, you're going to commonly see metabolic alkalosis, and that's due to the volume contraction and hypokalemia. So you increase sodium and water delivery to the distal nephron, and potassium and hydrogen secretion also increases. Now, not listed anywhere is the Barter and Gittleman syndrome. These are similar to loops and thiazide issues, because these patients who have these syndromes congenitally will have dysfunctions that affect what the loops and thiazides do, their mechanism. So they're similar in those sense. If you're vomiting, you're losing volume, so it causes a contraction and alkalosis, so you lose the HCl. So because you're losing the HCl in the vomiting, your body is going to try to increase the production, and in that production, your bicarb is generated as well, and you lose potassium. And then your urinary chloride will be low. Now, your urinary chloride here is a big useful technique in metabolic alkalosis patients, but the cause of that is unknown. So if you have a low metabolic chloride, such as 10 to 20, it's usually seen in vomiting patients, and that's due to the loss of chloride in the gastric secretion. However, if you have a high urinary chloride, such as greater than 20, it's a general symptom or sign for many other alkalotic diseases. Just keep that in mind. This is a key, can help you diagnose alkalosis. And if you're taking antacids, it's an excessive intake of calcium or alkali base. So it's usually calcium carbonate and or milk. It's often taken for dyspepsia. And so that's basically all I got. It causes hypercalcemia. It inhibits the NK2Cl, which has the same effects as the loop diuretics when you have hypercalcemia. And it also blocks the ADH-dependent water reabsorption in the collecting duct. So it can result in volume contraction, and then that can lead to metabolic alkalosis when you have antacid problems. With hyperaldosteronism, you either have an adrenal overproduction of aldosterone or you have an adrenal hyperplasia. You can also have an adrenal adenoma, such as Conn syndrome, and this is when you will see an increase in the potassium and hydrogen secretion. You will see hypokalemia, metabolic alkalosis, and resistant hypertension in these patients. And that's the resistant hypertension is usually in the setting of low potassium. And basically, in these patients, you'll often see no edema, and that's because your Na fluid is retained, causing your hypertension, and your compensatory mechanism is activated, and that's usually the ANP that's released from the heart, and that increases sodium and free water excretion, and that's why will result in a diuresis and normal volume status. And your urinary chloride will be increased, and that gives you that it's an alkalosis again. Just a quick review. Any questions about this?
No.
So we'll move on to the very last one for the night. And this one's the kind of the tricky one. So it's the most complex of the acid-base disorders, and because the anion gap determines the etiology of what you have. So this is a Chem 7 that you'll normally see. I don't know if Pete, when he's done his rotations, has seen something with a fish bone, or the doctors do a fish bone.
You're gonna fill that shit out every fucking day for every fucking patient.
Yeah. So usually when they do a M7, this is what they're testing for: is your sodium, potassium, chloride, bicarb, BUN, creatinine, and glucose. And then you fill that out as looks like a fish bone.
Sure.
So the anion gap, but the positive charge ions, it's only your sodium. You're not, and your negative charged ions is your chloride and bicarb. So the anionic gap is normally done with Na minus Cl plus bicarb. So why is anion gap important? So it results from unmeasured ions. So you have cations such as calcium and magnesium and other minerals that are in your body, and anions such as proteins and phosphates and sulfates. So a low anion gap can be caused by hypoalbuminemia, but it can also be caused by multiple myeloma. And usually it's IgG is a cationic, so it's positive charged, and will lower the positive ions or increase the negative ions. And that's an importance in anionic gap. So in acidosis, it's an acidosis where the primary loss of bicarb is the reason for the acidosis. The body will compensate with the retention of chloride. So your body will retain its chloride or increase its chloride, and that will cause a normal anionic gap. So obviously, when you're losing two negatives, if I decrease one and I increase the other, my normal chance of getting a normal anionic gap are high. But when you have an acidosis that's primarily due to retention of acid, when you're keeping more acid, such as ketoacids or lactic acid, your bicarb will fall, but your chloride won't rise with the fall of the bicarb. So it's not even. So in this case, you rise in the anionic is to compensate for the fall, or the rise in the acids to compensate for the fall in bicarb. So when you do this anionic gap, the result will be an increase in the anionic gap. And that's why you see the difference in diseases. So let me give you guys a problem, and this will help you understand it. So here, if your sodium is 134, your chloride is 108, what's the normal chloride levels usually?
95 to 105.
and your bicarb obviously is low, and your pH is low, so it's a metabolic acidosis. But your chloride is high, so when you do the anion gap calculation, you'll get 10, which is normal. Because, yes, your bicarb went low, but your chloride also went up. Does that make sense?
Mm-hmm.
All right, so in this example, yes, your pH is low and your bicarb is also low, metabolic acidosis. However, your chloride levels are normal, or slightly less, actually, because it's below 95. So in this case, this chloride did not increase, so that's why your anion gap is really high. And you can calculate those numbers, and you should get those values. So in non-anionic gap diseases, you're going to have either diarrhea, and that's due to the loss of bicarb in your stool. Acetozolamide is another one that can cause non-anionic gap metabolic acidosis. And because you can't reabsorb, so you lose the bicarb, and that's why it causes an acidosis. Spironolactone and Addison's disease. Spironolactone is an aldosterone blocker, while Addison's disease, you're just not making any aldosterone. So you have a loss of aldosterone effect, and you cannot excrete your hydrogen effectively, hydrogen ions, so your body will retain the hydrogen ions, causing an acidosis. And if you have a saline infusion, it decreases your renin angiotensin system, and that will decrease the hydrogen excretion. And then alimentation. Sorry, I think that's right. It's basically intravenous nutrition. So when you have metabolism, it'll increase your hydrochloric acid, and that will lower the pH. And usually this is offset in the hospital by giving them adding bicarb, but if you don't, then you'll see an acidosis. And then renal tubular acidosis are other causes of non-metabolic acidosis. So the mnemonic you can use from first aid is hard ass. So I've covered all of those and exactly why they cause the acidosis part. So any questions with that one? No. So we'll talk about anionic gap metabolic acidosis. Oh, let me ask you guys, what causes anionic gap metabolic acidosis? This is the mnemonic.
Mud piles.
Mud pile. So I gave you the first one here, methanol.
Uremia.
Okay, uremia.
Diabetic ketoacidosis.
Diabetic ketoacidosis.
Polyethylene glycol.
Propylene glycol.
Propylene glycol.
Yes.
Isoniazid and iron tablets.
Correct.
Lactic acidosis.
Correct.
Methanol.
Ethylene glycol.
Ethylene glycol. Salicylates.
It's the last one. Yep. So that's your mud pile. Yay. Yeah, it increases your anion gap, and that's the causes. And we're going to go through each of them rapidly. So with methanol, it metabolizes to formic acid, and this is a very big central nervous system poison. Usually you'll see patients will have vision loss or coma, and it's found in a lot of things such as antifreeze, de-icing solutions, and so on. So a classic scenario in a patient with methanol will be you'll probably suspect an ingestion of something, whether it be accidental or suicidal, or just an alcoholic trying to get his alcohol. The accidental will probably be like children. So they will come confused, and they'll have visual symptoms, and they'll have a high anionic gap metabolic acidosis. What is the treatment for these patients?
Fomepizole.
Fomepizole or ethanol. So you want to inhibit the alcohol dehydrogenase. which blocks the bioactivation of the parent alcohol to the toxic metabolite. So it basically blocks it to convert to formic acid. So fomepizole or ethanol, you can give these patients. Ethylene glycol, it metabolizes to glycolate or oxalate, and both are kidney toxins. They have both slow excretions in the kidneys. The glycolate is a toxic to the renal tubules, while oxalate is basically the thing that causes kidney stones, calcium oxalate crystals. It's also found in antifreeze solvents and cleaners. And a classic scenario with patients who have this will be suspected ingestion again, but they'll come with flank pain, oliguria, or anorexia because they have acute renal failure, and they also will have high anion gap metabolic acidosis. So what are the treatments for these patients?
Same thing.
Correct. Yeah. You want to inhibit your alcohol dehydrogenase again. So fomepizole and ethanol are similar. With propylene glycol, it's found in antifreeze. It lowers the freezing point of water. It's also solvents for IV benzos. In the past, the dose of IV benzos were somehow too high, and it would form toxic. It would be toxic. So when you gave too much IV benzos, it could be toxic. But now they don't do that anymore. It's metabolized to pyruvic acid or lactic acid, and has many adverse effects such as hemolysis, seizures, coma, and has multi-system organ failure. And then there's a high anion gap metabolic acidosis from the lactate, and the main clinical feature of overdose and CNS depression. But there's no visual symptoms or nephrotoxicity in these patients. So that's how you can differentiate. And then uremia, it's basically an advanced kidney disease. Early kidney disease can have non-anion gap acidosis because of the reduction in hydrogen excretion, so loss of tubule function, and increases in your bicarb excretion. Your chloride is retained to balance the charge, so that's why you get the normal anionic gap acidosis. However, once it's advanced, the kidneys cannot excrete the organic acids, and they will retain phosphate, sulfates, and urate, and other things that will increase the anion gap. So your chloride at that point can't balance off the loss of bicarb. And then in diabetic ketoacidosis, it usually occurs in type 1 diabetics. Insulin requirements rise and they cannot be met, often triggered by an infection. And then this is where you have your fatty acid metabolism and ketone bodies. These patients will present with polyuria, polydipsia. Polyuria because it makes them dehydrated, the glucose, and they're peeing so much as well. So the glucose will draw fluid into the tubules, and your urine output will increase. That will cause them to be dehydrated. So that's why you see the symptoms. You'll also see abdominal pain, nausea, vomiting. They'll present with Kussmaul's breathing, which are deep labored or rapid breathing, and they form. That's due to the acidosis. It's like a reaction or a compensatory mechanism. You'll get a high anionic gap metabolic acidosis due to the ketones. And what is a treatment for patients with DKA?
Fluids, potassium, insulin?
Correct. Insulin to lower the glucose, IV fluids to hydrate them, and then the potassium, because you can get hypokalemic when you're given insulin, so you don't want to see that, so you give them potassium. Yeah. Lactic acidosis is basically low tissue delivery to the low tissue oxygen delivery. This is where your pyruvates are converted to lactate, and when you have high levels, it can cause lactic acidosis and anionic gap metabolic acidosis. So clinical scenarios where you can see lactic acidosis will be patients with shock because they have decrease in their tissue perfusion. When they have ischemic bowel, obviously metformin therapy therapy, we know that the side effect is lactic acidosis, and seizures because they're contracting their muscles so much that it's causing the lactic acidosis or exercise. And then iron, there's an acute iron poisoning. So the initial phase of this will be GI effect. They'll get abdominal pain and direct toxic effects in the GI tract. However, within 24 hours of over poisoning, you can see cardiovascular toxicity or coagulopathies or hepatic dysfunction. And at the end, you'll see acute lung injury. This is typically in the later phase where you're going to see the anion gap metabolic acidosis also occur. And then weeks later, you can see bowel obstruction, and that's due to the scarring at the gastric outlet where the iron accumulates. And INH, obviously, it's an antibiotic medication for tuberculosis. An acute overdose causes seizures, and these seizures causes the lactic acidosis, which then in turn causes metabolic acidosis. And as I discussed earlier, aspirin is a 2-acid-base disorder. So shortly after ingestion, you're going to get respiratory alkalosis. However, hours after, you can get anion gap metabolic acidosis. Again, that's due to decrease in your lipolysis, uncoupled oxidative phosphorylation, and inhibits a citric cycle, and that will accumulate of pyruvate, lactate, and keto acids, which will cause the difference in the anionic gap. So an aspirin overdose, the pH can be variable because it's a mixed disorder, so it can be acidotic, alkalotic, or it can even present as normal. The CO2 will be low due to hyperventilation. Your bicarb will be low due because of the acidosis. Ventris formula to predict CO2, and the Ventris formula will generally predict CO2 which is higher than the actual CO2, and the CO2 lower than expected for compensation. So in a sample case, the patient has a pH of 7.3, bicarb of 14, and PCO2 of 20. What is the Ventris formula test?
So 14 plus 7 is 23 plus 8 is 31 plus or minus.
I got 29 plus or minus 2.
Oh, but I'm just dumb.
So the range that you should expect, well, you had 31, right? Which is 27 to 31. That's the expected PCO2. So in this case, the PCO2 is lower than the average. So they basically have respiratory alkalosis.
So just a respiratory alkalosis.
Correct. Okay. Well, they have metabolic acidosis, but they also have a mixed disorder of respiratory alkalosis.
Oh, if it had fallen within that range, then it would have been just... Oh, I see.
Correct. Yeah. So because it's below the range, it's metabolic and respiratory. Both. Any questions before I give you one last question for the night?
No. Bring it on.
All right. So we have a 16-year-old girl developed severe diarrhea after eating an undercooked hamburger at a family picnic. So staph-aureus, man. After 2 days of experiencing diarrhea, she presents the ED with moderate dehydration and orthostatic hypotension. Which of the following acid-base states is most probable in this patient?
So diarrhea, she's going to be acidotic, right?
Okay.
Is that right? Yeah, she's going to have a hard ass, right? She's going to have a non-anion gap acidosis.
Correct.
So let's go to pH. So either A, B, or D.
Okay, so you ruled out C.
Yeah, it's not C, it's not E, and it's not F.
Okay, good.
So now we gotta do our anion gap equation here to figure out which one of these is anion gap, or is a normal anion gap. So we have 140 minus 110 minus 18. So 130 minus 18 is what? 8? No. 12?
Yes.
So D is 12. 138 minus 110, that's 28 minus 22, so that's 6. So that's, wait, normal is 8 to 12. 8 to 12. Okay, so that's a below ion gap. And then 135 minus 90, that leaves you with 45 minus 10. Okay, so that's elevated. So A is out. So it's either B or D. So, oh, we got a normal bicarb versus a low bicarb. This is going to be a metabolic acidosis. So we're going to go with D because it's metabolic.
That is the correct answer, sir. Yeah. Basically, how he approached that question is pretty good. If you need explanations, shit. Yeah, I mean, I probably couldn't have explained it any better. But C, E, and F, well, obviously are alkalotic because their pH were also high. And then A would be the mud piles, so they would present with an anion gap. So yeah, that's all I got.
That was good. That was good.
Okay.
Yeah, like when it comes to memorizing all those fucking shitty charts, if you remember mud piles, if you just have that down, and then intuitively you just kind of figure out what other things are, then then you should be good to go. Like, I only remembered diarrhea was a non-anion gap because I knew it wasn't in mud piles, because the D in mud piles is diabetic ketoacidosis.
Yeah.
And I do know that poop is basic. So when you're pooping all of your bicarb out, you're going to have an acidotic state. And in the reverse, vomit, you're puking out all of your gastric acids, so that's going to lead to, you're puking out acid.
Alkalotic state.
Alkalotic state, right?
Yeah.
So, well, actually, didn't you just mention that if you're puking in, pooping,
yeah,
you're going to have a mixed?
Yeah, when you're puking, you're gonna increase that hydrogen chloride secretion, but your bicarb will also increase. So it's an alkalotic situation.
Nice.
Because you're losing HCl. Yeah.